Good afternoon, ladies and gentlemen. Thank you for the opportunity to present today. My name is Deirdre. I'm the Assistant Director of Nursing in the Cork University Hospital. We recently did a quality improvement project on one of our acute surgical 35-bedded ward. In relation to the treatment of patients, we wanted to reduce the time taken to treat patients. So our project title was Pathway Granularity and Solutions to Barriers to Sepsis Diagnosis and Treatment. As we all know, sepsis is everybody's responsibility. It was essential to have a strong multidisciplinary team across the implementation of this project. So we began with a strong team, starting with healthcare assistants, student nurses, porters, pharmacists, surgical registrars, porters, and lab technicians. As I mentioned, sepsis is everybody's responsibility, and it was essential to have everybody on board from the start to ensure a culture change. Also central to the project was respect for all team members to ensure engagement and successful change to practice. We developed a name statement. We looked at 8 charts in November 2015, and we established that the average time to treat a patient from when they triggered for sepsis to the time they were reviewed by the doctor was 53 minutes. Our aim was to reduce this down to 30 minutes by March 2016. We collected the data as mentioned from the 8 charts. We are all aware that the national guidelines stipulate that you need to treat the patient triggering needs to be seen by an SHO within 30 minutes, and a patient with an early warning score of 4 to 6 needs to be seen by the SHO within 30 minutes, and a score over 6 needs to be seen immediately. Our 6 or 8 points are detailed here on the run chart, and you can see the wait times, the median being 45 minutes. So we then developed our driver diagram. As mentioned, the aim from the data in November 2015 was to reduce the wait time from 53 down to 30 by March. We established the primary drivers and the secondary drivers. Primary drivers initially being the building a patient safety culture, which is involved the E&B, and to get the multidisciplinary team on board. Moving on then, we needed to look at prompt recognition, the use of early warning and national screening tools, and to ensure there was adequate education provided in regard to recognising the sepsis patient. Moving on then, timely diagnosis, again, education was central to this, and developing a standardised process and clarifying the roles of everyone involved. Early identification, ensuring the delivery of the sepsis 6 within the first hour, continually monitoring the patient and the delivery of the 3 and 6 hour bundle, and a dedicated sepsis consumable to hand. We tried the pack first initially, the sepsis pack, and we moved on with the sepsis trolley, which we'll discuss later. We also looked at continuous learning. We reviewed the case studies and the root cause analysis of events and ensured feedback to all the team members. I'll hand you over now next to Rachel Hardcastle, who's an RGN on the surgical ward.
So this is a picture of the sepsis project workshop. We used to meet regularly and brainstorm, and during these sessions we were able to use stake mapping to map out the problems that were causing delays in diagnosis and treatment of sepsis. So the areas highlighted with the red dots were kind of the main areas that we found that were causing the delays in the treatment of sepsis. So just the project team was all the doctors, the nurses, management, the CNM2 for deteriorating patients. We also involved the ward pharmacist and the biomedical scientist in the hospital as well. So in the end, we ended up with this fishbone diagram. So the 4 key factors that were delaying the treatment of sepsis were the process, technology, people and organisation. So just the awareness of the roles and guidelines, completing the processes, the access to lactate and the delays of bloods to the laboratory seemed to be problems. Also the vast workload of the staff and the wrong doctors being called, and the people not sure when to escalate the situation to the more senior doctors. So these are all the kind of main things that we would try to work on and trying to get down the time in treating sepsis. I'll just pass you on to Yvonne now. She's the healthcare assistant on the team.
Thank you. So from there, we went on to do a brainstorming session with the staff to give suggestions on how to treat sepsis within the time frame. We said that we needed more education and awareness. Possible posters and flyers would be good for this. So we made and put together some prompt cards on the triggers and treatment for sepsis, so that this would be given to each staff member on the ward. We then thought of possible maybe a sepsis pack, but we moved on quickly from that because we came to the conclusion that it wouldn't be big enough to hold the equipment that was required for the treatment. So we came up with the idea of a sepsis trolley. So working together with the healthcare assistants stocking and checking, the doctors with their input, we streamlined the essentials needed in the treatment for sepsis to avoid confusion and delay on finding equipment was a key factor. We then included Ciara, the ward pharmacist. We made a list of the antibiotics used on the sepsis trolley, and the pharmacist gave us guidelines on the storage and the replenishment of the antibiotics used. So then it was the induction of the sepsis trolley onto the ward. Our plan was that it would be used 100% for every sepsis patient that triggered for sepsis. That we would also have a dedicated area for the sepsis trolley, which was visible to every member of staff, and that we would have the labels clearly on the shelves to have clear allocations of the equipment for easy access. We predicted that the patient or the trolley wouldn't be used for not just sepsis patients, it would be used for other deteriorating patients, or that the trolley might not be used at all, or that the trolley will not be replenished. So what we done was we were present on the first day of the rollout of the sepsis trolley, and the doctors then signed and commented after each use so that we got feedback on what their thoughts and opinions were on it. So we found from our study that the trolley was used 2 to 3 times a week, and that the doctors gave us great positive feedback that they found it beneficial and it reduced their time in gathering all the different equipment that they used and needed for sepsis. One doctor in particularly said that he would use it for other deteriorating patients as it saved him time, and we acted on on the cost of the actual trolley from procurement for our ward, and we got the healthcare assistants to have a stock list that would check for dates and expiry dates, and also to have a tag that would be put on the trolley so that we'd know when it was going to be used, so it wouldn't eat up into our patient time as well. And from then we went on to involve the labs, because it's vital that the labs treat sepsis bloods urgently. So we designed it and developed this sticker so that it would stand out and that they'd treat this urgent as opposed to treating routine bloods before the sepsis bloods. We got this made in our stationery within Cork University Hospital, and the labs found this helpful to identify the bloods, and this also heightened the awareness of sepsis and the need to get it treated within the time frame. I will now pass you on to our surgical SHO, Roxanna.
So, in November, the time to review a patient by the NCHD was 53 minutes. In May, we audited 25 charts of patients who triggered sepsis, and the result we could see in the diagram. The mean time to review a patient was 43.7 minutes. However, we noticed an astronomical event. Looking into the chart, there was a patient who triggered sepsis in the middle of the night. The whole on-call surgical team was scrubbing the theater for a major case. Communication was maintained over the phone, and some elements of sepsis 6 were delivered. We also noticed a chart where it's documented end of life, and then another chart where there's no documentation. If we exclude the astronomical event, the mean time to review a patient is 30.91 minutes. So to conclude, in 2015, from January to end of May, the numbers of patients, we had 4 patients admitted to ITU from the ward. In the same time, in 2016, while we were running the program, number of patients admitted to ITU were 3. We also obtained a 33 reduction in the length of stay, resulting in reduction of cost. And When we start the audit, we develop a simple questionnaire for the multidisciplinary staff on the management of sepsis and hand it to 11 staff members to identify the baseline knowledge. While staff survey felt that they understood sepsis, all 11 samples did not know which blood test to take from sepsis management. And in the same questionnaire, when we finished the audit, we noticed an increased knowledge in staff knowledge of sepsis. And maybe the most important reduction of time for patients who trigger sepsis to be reviewed by the NCHD team. This is our team with the sepsis trolley. And just a quick view of our poster. Thank you very much.